Sound check, sound check. Hi, folks. Professor Gulliford here. What I'd like to do is share with you some information and some experiences with long COVID, meaning COVID that is slow in recovering, and we are seeing so much of that today. The patients are calling themselves long haulers, and if you Google that, you'll see various groups that have sprung up to try to support each other as they have these long COVID recoveries. Let me do a share screen here and share computer sound and video, and we'll call up our PowerPoint on post-COVID recovery and rehabilitation. The last year and a half, I think it's actually 20 months now, we have just been consumed in my health system with taking care of COVID patients. And at one point, we had 4 intensive care units completely full of COVID patients. I believe that was a total of 360 roughly inpatient COVIDs in intensive care. Now we're down to 1 unit, and the focus is gradually shifting. We've got all these folks who have survived COVID, and that's an awesome thing. But it is a long road back. So post-COVID recovery and rehabilitation, the recovery can be long and difficult. I'm sure you've already heard that from your own clients, friends, family, in your communities. The patients are calling themselves long haulers, and their conditions have been called post-COVID syndrome or long COVID in the medical community. Some of the things that these patients experience are fatigue, shortness of breath or difficulty breathing, cough, joint pain. Gosh, I have a patient who had relatively mild arthritis before COVID and now is just about debilitated with joint pain. We're hoping to help that client. Chest pain, memory concentration problems, sleep problems, muscle pain, headaches, rapid heartbeat, palpitations, you might say. Continuing loss of smell or taste. I have one client who now is, I think, 13 months after the acute recovery and does not have smell or taste back. Depression, anxiety, fever, dizziness upon standing, and then worsened symptoms after physical or mental activities. The most significant actual damage from COVID is heart, lung, and brain. What we're seeing in some patients, and it's very difficult to predict who, but what we're seeing in some patients is heart muscle damage, permanent damage, sometimes relatively mild, sometimes pretty significant. This may increase the risk of heart failure or other cardiac complications, and heart valve problems sometimes are appearing months after the patient had apparently recovered. Lungs, of course, it's a viral pneumonia. That's what COVID is. And what we're seeing is long-standing damage to the alveoli, scar tissue, what you might call pulmonary fibrosis, and this can lead to long-term breathing problems. One thing that definitely helps is pulmonary rehabilitation, and we're doing a lot of that. Brain, even in young people, COVID can cause strokes, seizures. Guillain-Barré is now clearly related to COVID recovery. We're seeing quite a few cases. COVID-19 may also increase the long-term risk of Parkinson's and Alzheimer's. There's not enough data to say that convincingly, but what we know is that other coronaviruses have had a connection to Parkinson's and Alzheimer's. Hepatic and renal, well, we do have microemboli. I'm sure you've heard about the blood clotting issues in COVID. And what we think is that microemboli, small blood clots, are damaging the kidney and liver. The liver does a remarkable job of regenerating, and recovering. The kidneys do not. So we are seeing some folks who wind up on dialysis even after they thought they had completely recovered from COVID. Mood and fatigue. Patients with severe symptoms of COVID-19 wind up in the ICU. They wind up on a ventilator. It's similar to combat, folks. The stress of that experience is similar to being in combat. The patient does not know if they're going to survive, and very likely will wind up with post-traumatic stress disorder, depression, anxiety. Let's see here, chronic fatigue syndrome, complex disorder characterized by extreme fatigue, which worsens with physical or mental activity and does not improve quickly with rest. So we're seeing lots of neurological issues. How about kids? Kids and teens, most of them escape relatively unscathed. It's unclear why some have continuing symptoms and others don't. Heart inflammation is a big issue. And here's what we want you to watch out for. Young athletes who may have had a perfectly normal heart before COVID could have some damage. And we're seeing some athletes that return to practice or return to competition, and they're not doing well and may even wind up in the emergency room. So any young athlete who's had COVID should be screened for heart damage before they resume activity. Probably an echocardiogram would be the best way to do that. You've heard of MISC, multisystem inflammatory syndrome in children. Thankfully, it's a rare condition, but we've had several cases here at the University of Oklahoma Medical Center. These kids should definitely be followed by a pediatric cardiologist. How long is long? Well, we know that 19 months at least, because we have patients who recovered from the acute phase and have not fully recovered in 19 months. So, we really can't say definitively how long is long. Some patients who contracted the virus early in 2020 have still not completely recovered, and it will take longer to fully understand that. Some patients, I'm sorry to say, I do not believe will ever regain full function. Treatment, long COVID clinics are emerging. Right now, you can attend a long COVID clinic at Johns Hopkins, at the Cleveland Clinic, at the Mayo Clinic. And I think that these will proceed to develop in other states. There will be so many patients seeking post-COVID care that it essentially becomes a subspecialty of its own. In the absence of a long COVID clinic, the pulmonologist is where to start. And then we can, get the appropriate referrals. Pulmonary rehab and physical therapy can definitely help. Patients should be prepared for a lengthy and gradual recovery. Brain retraining is very encouraging in these patients. I was just talking to a psychiatrist on our staff here who is having excellent success in the same sense that stroke patients can benefit from brain retraining. These post-COVID patients can clearly benefit as well. The brain needs to understand, it needs to accept the fact that the survival phase of just getting through the acute COVID experience has ended, and it's safe now to return to normal brain functions. The brain fog, which patients describe, is because their brain is in survival mode, trying to just focus on surviving. And that is clearly due to the low oxygen levels that were experienced during COVID. Continuing to boost immunity is so important. I have an excellent list of supports that have been helpful and actually recommended by our infectious disease chair. Think of how things have changed, that an MD who's at the top of the infectious control ladder is recommending natural supports now. Case studies, local case study 1, 39-year-old male, vigorously healthy, former college athlete at Oklahoma State University, ran daily, coached several sports, contracted COVID on a poker run, along with many other participants. We actually saw a total of 20 individuals from that poker run who contracted COVID. He was recovering well at home and then suddenly very short of breath. His pulse ox dropped to 75. It had been in the low 90s, and in one day went to 75. Admitted at a local facility here for 11 days on Vapotherm, did not get intubated. Now 15 months downstream from discharge. His PFTs, pulmonary function tests, show a vital capacity of 69% predicted. We don't have a PFT before the COVID because there was no reason to do one. He was vigorously healthy young man. But assuming his lungs were normal at that time, he's lost about 30% of his lung capacity. Continues with brain fog, shortness of breath on exertion, quoting the patient, "Wonder if I'll ever get back to normal." Still off duty as of this writing. Case study 2, 27-year-old male, campus police officer at the University of Oklahoma, contracted COVID on the same poker run, admitted to OU Med Center, Vapotherm and BiPAP, 15 days, did not get intubated, discharged but significantly short of breath. PFT showed just mild restriction. The pulmonologist made a great call and said, "I think this is something more than the lung." And echocardiogram showed a damaged aortic valve. COVID had attacked the aortic valve, and his cardiac ejection fraction was 34% on the day of that echocardiogram, with 75% being normal, something above 75%. Wow. Patient underwent aortic valve replacement 13 months after his initial discharge. I believe that was now 2 months before this recording. Much better now. That was definitely the problem. Follow-up pulmonary functions and echocardiogram are now normal, and he is back on duty. But I guess 15 months downstream. So there you go, folks. Long COVID. We're going to be taking care of these patients who recovered from COVID for a very long time. And, there's no expectation that COVID is going to be over. The acute phase, the pandemic, will in fact be over. I believe this spring. That would be spring 2022. That's what our infectious disease chair feels as well. So hopefully that was of some help. We'll be taking care of these clients for a very long time, and maybe you'll have a little better understanding now of their challenges. Thank you.